Well, thank you so much, Andrea, and it's always a pleasure to be here. I see some very friendly and faces in the crowd. So when she sent me the email, it was an easy decision to say yes to come back. And it was just, I think, just a few months ago that we spoke about the knees, right? And we've been having some great success with that, trying to alleviate people's chronic knee pain using radio frequency waves in the knees, and very excited. So you may wonder, well, how do we go from working on knees to veins? You say, but that poor guy, he doesn't know what he wants to do with himself when he grows up, right? And part of that's probably true. That's right. I see some other people are still trying to decide too. There's nothing wrong with that. I think part of it is just enjoying what I do and being a lifelong learner. And I think anyone in this room, whatever you do, whether it's business or teaching or whatever your field of expertise is, a lot of times you enjoy sort of branching out a little bit. And so how the Vein Center came about, actually I had really no prior knowledge of it. It was Brian Finley. For those of you who know Brian, he's one of the senior administrators here at the hospital. He actually caught me in the cafeteria once. So my mind was on a salad and he was thinking about veins. So he came over and said, hey, have you ever thought about, or would you have any interest in thinking about working with another doctor on a vein center? And it really caught me off guard because I never really thought about that. As I mentioned before, I'm a family doctor by training. And then I did an extra year of a sports medicine fellowship. So right now I do all musculoskeletal medicine just across the street, and really very much enjoy what I do. So thinking about veins really did catch me off guard. But when I learned more about it, it turns out that it's an ultrasound-guided procedure, which as many of my patients know already, we use the ultrasound a lot in the office for hip injections, shoulder injections, and dry needle procedures to treat chronic tendinosis. So we're already using ultrasound, and then it also combines radio frequency, radio waves. And remember last time, when we talked about radio waves, think heat, right? So once I learned more about it, I thought, well, this sort of makes perfect sense because it's a blending of those two things, using ultrasound guidance to use to direct a radio frequency tipped catheter. Only in the knees, we were using that to actually try to burn the pain nerves so we could interrupt the signal from the knee up to the brain, right? So we're using heat to burn a little section of that. In this case, we're actually using heat inside of a vein to actually close the vein shut, okay? And that may sound kind of unusual right now, but we're going to go through a presentation. And has anyone come to the Baptist Easley vein screening that we've offered? There's been about, yeah, I see some faces. So a couple people, this will be very familiar. For those who've already seen it, hopefully you'll get some more information. Now I'm going to maybe expound on a couple things, more so perhaps than we did for the vein screenings. But for everyone else, this is fairly new, so I'm hoping that with that introduction, we'll be able to tie together the different technologies that are used and the purposes for it, and hopefully give you a better, more comprehensive understanding of what we're doing at the Vein Center. So we have a PowerPoint, and we'll start here. So a lot of times when you think about veins, you just think about cosmetics. You know, what does the vein look like? A lot of times people see varicose veins down in the leg, and so certainly there is a cosmetic part to it. But as we go through the presentation, hopefully I'll be able to show you that there are a lot of very good reasons to treat what we call venous insufficiency when the veins aren't working as they should, to try to decrease the risk for things like blood clots or venous ulcers or chronic fatigue in the legs, swelling in the legs, those sorts of things. So really the cosmetic side is one piece. This is more to try to prevent the long-term consequences of the veins not working as they should. So hopefully that'll become more clear as we progress here. So about venous disease. So what causes it? The symptoms, how might a person who has venous disease present, or what may they describe to their physician, and what are some options for treatment? So venous disease, an introduction. So certainly anything in medicine you want to make sure there's a high enough prevalence for it to be worthwhile to spend time and energy in, and certainly there is. More than 45 million Americans have venous disease. There is a slight predominance in females compared to men. And less than, so less than 4 out of 100 of people with venous disease are actually getting treatment for that. And what's interesting, that third point there, venous disease 5 times more prevalent than arterial disease. But we rarely talk about venous disease, right? Everyone thinks about the arterial disease, and that makes sense because certainly from that standpoint, arterial disease is going to present much more acutely, meaning you're going to have symptoms much more acutely. Arterial disease, you think about the coronary arteries. People think about heart attacks. You think about the cerebral arteries. You think about stroke, that sort of thing. So obviously, understandably so, there's a huge amount of significance placed on arterial disease, as there should be, but no one really focuses on the venous disease, and at least not here in Easley, and that's what we're trying to do, is to provide a service here. So on the far right side, you can see why do we care? Why are we trying to treat this? Well, you do have an increased risk for blood clots, and I think the way to understand this is there's different reasons that people get blood clots, right? Sometimes people are what they call hypercoagulable. Just means they're more likely to get a blood clot because they have a type of bleeding disorder or coagulation disorder where they're prone to causing clots, forming clots. That's one thing. Another thing is trauma. Trauma to the vessel lining of a vein would make you at increased risk for a blood clot. And the last one is stasis, meaning the blood is not moving as it should. Think about the difference between a briskly flowing river and a pond, right? Think about a pond, how it gets murky. There's a lot of things that can grow in it. Think about that in terms of how easy it would be to set up a blood clot there, but when you have good flow, like a briskly flowing river, much less likely. And you'll see in venous disease, what happens a lot of times is we're describing venous reflux. So the blood goes one way as it's trying to make its way back to the heart, but if the valves aren't working properly, it goes back down because gravity pulls it back down. So you develop a pool of blood in the lower extremities, and that makes you at increased risk for a clot. Does that all make sense? Okay. Skin color changes. A lot of times you'll notice if someone's wearing shorts, from about halfway down the leg down to the ankle, the skin just turns kind of brownish, copperish appearing. A lot of times you'll see that. Both sides, about the same level, very healthy, normal, and then it just changes. That's what we call stasis dermatitis. It's just a fancy way of saying it's a change in the skin because of stasis, means the blood's just not moving, venous disease, okay? And ulcer formation. My partner in this, Dr. Moister, he's actually a plastic surgeon who works at the wound care center here. I hope someday you'll hear from him. I think you'd really enjoy that. But he works with a lot of folks who have developed venous ulcers, and that was a big part of his interest in pursuing a vein center here at Easley. Thank you, Andrea. So here's some different pictures. I think everyone's probably recognized some of these skin findings in themselves or friends or family. They're real small that you can't even really feel, but they're just under the skin surface there, telangiectasias, varicose veins. Superficial phlebitis in the top right-hand corner. That just means inflammation of the vein that's close to the surface, and we'll talk about the difference between superficial veins and deep veins. And then the bottom right is a venous ulcer. Certainly, we want to try to prevent that if possible. So, for patients who have venous disease, what might they feel? What are their symptoms? You see a fairly long list, certainly not exhaustive of all the symptoms you could have, but a lot of times people do have heaviness in the legs, they feel leg fatigue, throbbing, burning, restless legs. How many people have had a diagnosis of restless legs but can't really, there's no underlying cause? So, just to be clear, I'm not saying that it's definitely attributed to venous disease, but certainly that's one thing to think about in a person who otherwise is healthy, but they have restless legs and we just can't figure out why. So just think about, could it be your veins? Numbness, swelling, peripheral edema. Sometimes people have lower extremity swelling and the doctor does all the blood work. They check your heart, they check your kidneys, check your electrolytes. Everything looks good, but for some reason you're still collecting fluid in the lower extremities. Something to think about. Could it be venous disease? Can you all see okay over here? I'm sorry. So causes, not to be pessimistic, but if your mom and dad both have venous disease, about 9 in 10 chances that you'll have it as well. So genetics are a big part. So your parents were very generous. They gave you a venous disease, right? Anyone who never thought their parents were generous, this changes your mind. So age, really it's across the board from teens to elderly. Venous disease, as you can imagine, with a lot of things, it worsens with age. And women, as you can see there, and as we talked about earlier in one of our first slides, the prevalence is much higher in women, probably in thinking with relationship to pregnancy and the different trauma. You know, the growing uterus puts compression on the venous system, and so over, you know, for not the whole in pregnancy, of course, but as the uterus grows large enough, once you get to a certain number of weeks where it can compress the main drainage system, you can imagine that the veins are under increased pressure. So it could be that women who've had multiple pregnancies are higher risk for that reason, that they've had some trauma in their 20s or 30s from pregnancy. Standing professions, so people who work in a mill, people who work in an assembly line, people who are standing in one place or just minimal movements throughout an 8 or 12-hour shift. As you can imagine, gravity is working that whole time, pulling that blood down. And without the calf muscle pump, you don't have that mechanism to squeeze the blood back up into the heart. So anatomy, I want to talk briefly about this because this is really important. Probably most people have heard of a DVT, a deep venous thrombosis, right? A blood clot in the, sorry about that, in the deep system. This takes about 90% of the blood back, the deep system. If you get a clot here, that's concerning, okay, because that can go back up, can go to the lungs, etc. So we take that very seriously. The superficial venous system, those are the veins that we're talking about in this particular setting. The ones that are superficial, of course, just means closer to the surface. So it's the superficial ones that we're looking to treat here. Now the way it works is it's an intricate set of highways. So the superficial drains in through these perforating veins, goes through the layer of muscle, down into the deep veins, and then the deep veins carry the blood back up to the heart. But you can imagine if the superficial system is not working as it should, it's not properly transporting that fluid into the deep system to get taken back up. So it remains there and it becomes this sort of stagnant fluid collection, and that's what predisposes you to clots, to the fatigue in the legs, etc. So that's a key point. Remember the difference that there's two different systems of veins, one close to the surface and one much deeper. So here, one of the most commonly impacted is the great saphenous vein. Runs from the inside of your ankle, runs up the medial side or the inside of your calf, just behind the inside of your knee, and runs up on the inner thigh, goes all the way up and drains into the groin. Now, as I mentioned, it's the most common one to be treated. This vein comes up quite a bit. Has anyone in the room had a bypass surgery, or friends or families had a bypass surgery? Yeah, so you're probably familiar with this particular vein. A lot of times the great saphenous vein is used for one of your bypasses. Okay, so if anyone in the room kind of has this lingering question, well, why are we going to get rid of some of these veins? You're talking about using radio waves to close a vein. That doesn't make any sense. Why would you close a blood vessel? Don't we need that? Well, we already know that people do quite well with this vein removed, because we use it for bypasses. Cardiac surgeons use this to bypass coronary arteries that have become clogged. So a lot of times that's how you know somebody's had a bypass. You'll see a big scar. Of course, now they use it through small portal holes. It's much more aesthetically pleasing, but that's one of the veins that they use very commonly. The small saphenous vein actually goes just about the middle of the calf, starts on the outside of the ankle and runs straight up. And then most of the time, about 60% of the time, that drains right in the back of the knee. It's called the small saphenous vein. Now, just a brief review of the difference between veins and arteries. Of course, as the heart pumps, it's going to pump blood to two places, right? It's going to pump blood simultaneously. Depending on where the blood is in the heart at that time, it's either going to get pumped to the lungs, where it's going to pick up oxygen and then come back to the heart, or it's going to get pumped to the body, and then it'll come back via the veins, right? So the arteries, of course, are the blood vessels where the heart is pumping it away from the heart. It's oxygenated blood. It's taking it to the tissues, and the veins return that blood to your heart. Now, it makes sense the heart is going to be squeezing. That's going to be the forward flow for the arteries. Well, what's the forward flow for the veins, right? What brings the blood back? We always think about the heart pushing it away. what brings the blood back. And it actually turns out that you have what they call a calf muscle pump. So it's a combination of the muscles in the calf and the thigh that as those contract, they increase the pressure and squeeze it forward. But in order for that to work, you also have to have valves in the veins. Now, we also oftentimes talk about the valves in a heart, right? We think about people who've had aortic stenosis or mitral surgery, that sort of thing. So we know well about the 4 valves in the heart, but valves and veins are very important, and they really don't get much attention. The way I like to think about this is almost like taking an elevator back up to the heart. So the arteries, remember, pump the blood away from the heart, but now once it gets down to the feet and ankles, how does it get back up here? Well, the calf muscle squeezes it up to a level, and then in between contractions, the valve closes to keep it there, and then it waits for the next contraction, squeezes it back up. So it's sort of like taking an elevator. Does that make sense? Up the whole column back up to the heart where it can get oxygen and return the whole cycle. But as you can imagine, if those valves aren't working correctly, that process, which is quite an intricate one, can begin to fall apart, and we can see the consequences that we talked about earlier. So here's a little video showing what happens. There's a calf muscle contraction, right? So if you get up on your tiptoes, that contracts and then squeezes the blood up. Okay, wait, there's a contraction. See how the blood flows up, whoop. And then once it stops, the blood starts to, because gravity is still going to work on it. Once the contraction stops, it starts to flow down, but then the valve closes, so it keeps it there. And then it waits for the next contraction. Then it squeezes it up to this valve. And then that one closes, and then squeezes it up to the next. And that works until it can bring it back up to the heart. So here's a diagram of the valves themselves. I kind of like to think about it. Remember the old Western movies where they have, y'all don't ever watch old Western movies? That's a joke. But remember the saloon doors where someone would come in through the saloon, right? And they'd blow the doors wide open. Kind of think about the valve like that, where those 2 doors just come wide open. And then as the doors close, they should touch here, right? So this, open it up, and then you close it, and then the blood should stop there. But there's a couple things that happen. Over time, the walls of the vein get weak, and so they start to dilate, right? They start to get larger in diameter. So these little leaflets, they're still trying to do what they can, but look at all this that can sneak in between it. So that's one thing that can happen. The vein itself can dilate, or 2, you could have a primary process where the leaflets themselves aren't working. So the leaflets just are kind of flailing, or they're just sticking to the side. They're just not working as well as they should. So there's a couple different ways that this can be interrupted. And here's a picture of reflux. So whenever you think about reflux, just think about something going the opposite direction that it was intended to. So, of course, most people think about gastroesophageal reflux, right? Heartburn. As you swallow, it goes down the esophagus into the stomach. Anything that goes from the stomach back up into the esophagus is going the opposite direction, right? And we know that's not a good feeling because of the burning. We know what that can do to the esophagus over time. So anytime you see reflux when you're reading something medical, just think about, oh, that means it's not going the proper direction, the way it was designed to. So a couple more definitions. Reflux, this is also called venous valvular insufficiency. So insufficiency just means it's just not capable of doing the job it was designed to. And we already talked about the valves in the veins. Now, a lot of times people have heard about hypertension, right? Fancy way to say blood pressure. We think about arterial hypertension. Well, it turns out if you collect fluid in what's supposed to be a low pressure venous system, over time that can cause venous hypertension. So again, it just means high blood pressure, only in this case it's in the venous system instead of the arterial system. And a lot of times, as you can imagine, that increased pressure over time, it's like a water balloon, just stretches and stretches and stretches over years and decades, and that's how we get the weakening. And on the right side there, obstruction, you can think about how you can form a clot. Again, in the superficial system, if it's close to the surface, what we call a superficial thrombophlebitis, a lot of times you can just treat this with anti-inflammatories and a warm compress, and that'll get better on its own. It's the deep ones that we really get worried about, because those are the ones that could break loose, what we call embolize, and that could travel up to the lungs, and you get a pulmonary embolus. So those are the ones we really worry about. And so we're trying to prevent blood from becoming stagnant in the lower extremities and putting somebody at risk for a blood clot. So we've talked about venous disease itself. We've talked about the symptoms, what a person may feel or experience if they have the disease. And now let's talk about some options for treatment. I was hoping Brian Finley was going to be here because he was the model for this picture. But I think he had another meeting today. But tell him you appreciate his contribution to the medical literature. So as you can see, there's greater pressure. This is called a gradient, a pressure gradient. So it's greater here, less here, less here. And so it starts here, and you know fluid flows in the direction of least resistance, right? So if you squeeze it really hard here, it's going to go to wherever it can, which is going to be the next level. You're squeezing it here, but not quite as much, and then it's going to keep its way up. So you can see that doesn't fix the valves. The valves are still leaky. You still have a dilated blood vessel, but this is trying its best to actually squeeze those blood vessels together to try to bring the blood back the way it should. Again, it doesn't cure it, but it can help with some of the symptoms. And of course, this is where we start. Unless someone already has ulcers, unless they already have a disease like that, which needs to be treated right away, this is where we start. And certainly, I think this picture is just to say the importance of regular activity, as we know how good this is for blood flow to decrease your risk of clot. So you definitely want to stay active, and also you want to try to elevate the legs whenever you can. And also you want to try to avoid heels, because remember we talked about the importance of the calf muscle pump, which squeezes the blood up. You really want to avoid heels because that you kind of start to walk on the toes. You don't have that nice rolling motion where you land on the heel and then you move forward and the calf muscle pumps like you're trying to come up on the tiptoes. So you really want to try to wear a flatter shoe, okay? So now, minimally invasive procedure. You're thinking, okay, finally, we get to where we started, right? Where we combine the ultrasound and the radio frequency. So here's a little picture of it. And remember, we talked about the great saphenous vein. That's a picture here. Goes down to the knee. And what this is trying to illustrate is this is a small catheter. It's put in through a very small incision here, and it's fed up just about to where the great saphenous vein drains into a larger vessel up in the groin. Let me back up. There we go. So it's fed up to about here, and then there's medicine that's injected all around, sort of like a donut of medicine all around the length of the vein for local anesthesia. And the patient's awake during this. It's an outpatient procedure. Takes less than an hour. So once all that is complete, then this is where the radio frequency comes in. This catheter, about 7 centimeters long, heats up so much so that it actually seals the walls shut. So you can seal this section, and then you pull the catheter back, and then you seal the next section, and then you pull the catheter back and seal another one until you basically seal that whole vessel shut. And again, not to be redundant, but you say, well, why on earth would you want to close that blood flow? Don't we need that? Well, remember, there's a superficial system and there's a deep system. The problem with the superficial system in this case is that it's not doing its job properly. So the valves in that system are no longer working, and so the blood is not going in the one direction it should. So if you think about it, by closing this, the blood no longer has an option to get into that vein and just sort of sit there and put you at higher risk for clot. So now you actually seal it shut. It's sort of like saying, okay guys, I-85's closed down. No more cars on I-85, right? That's what it's doing. So you're not going to get a traffic jam on I-85 anymore because you're not even going to have it open. Does that make sense? You're going to seal it shut. And that's where you use the ultrasound to access the vein. It's really pretty neat. You see this little black circle on the ultrasound, and you can watch your needle come down, and you get it right there, and that's how you start the process. The whole thing's made through a very, very small opening in the skin.
What happens to the blood that's already in that vein?
Well, it's going to be compressed out because it's going to have two different ways to leave. The blood that's currently there, remember, it could this up here can drain. Whatever's remaining can go into this system here and then go back up, and whatever's here can still come out through the tributaries. So it'll all be moved out, and the heat itself is going to dry up some of that as well. So again, walk in, walk out procedures, just like we do for the knees, right? There's no overnight stay. The 5-year success rate of closure for this is very high, 90 in the 90%, and very low risk for complications. So what happens afterwards? Well, people would continue to wear compression stockings for about 2 weeks, and really people are encouraged to walk as much as possible. So, you know, sometimes people walk literally miles after this procedure. Showers are okay the following morning, and as you can imagine, you want to wait about a week before any type of high impact exercise or soaking, and you know, just general good precautions to decrease risk for infection or any other issues. Stay hydrated. Remember we talked about before the risk for blood clots. One of them is vascular stasis, or the blood just not moving. That's when you're dehydrated. So you want to have a briskly flowing river, so you want to stay well hydrated. And then you have a follow-up in about 3 to 7 days with another ultrasound to make sure that there's no blood clot. Some of the complications or more adverse events, some bruising, but this is not seen as much. Our plan is to use the radio waves, radio frequency, and which has seemed to show less bruising afterwards than the laser. Okay, some mild swelling, and again, very low risk for blood clot. Again, because the ultrasound can be used for precise location, you want to be close enough, but not too far away from the junction of where the great saphenous vein empties into the larger vein above it. And so that's how ultrasound, you can actually put a little measuring tool on the ultrasound. You know exactly, you want to be between 2 and 3 centimeters from where that vein empties out, and that significantly lowers your risk for developing a blood clot. So just a couple more slides. Phlebectomy. Anytime you see that prefix, phleb, like a phlebotomist, that's the person who takes your blood, right? Accesses the veins. Ectomy just means taking it out, so it's just a fancy way of saying taking a vein out. In this case, there's actually a small, looks like a little sewing hook, sort of, that as you numb up the skin and just kind of go in and reach out and pull out a little section of vein. Now you want to close the main river first, okay? So you'd want to do the procedure in the great saphenous vein or the small saphenous vein first, and then if anything remains, then you could go back and do the phlebectomy. And here's some pictures. Again, even though it wasn't done for the purpose of cosmesis, you can still see that a lot of these folks did have a very positive result. And then here is a very similar topic, but a different mechanism. Sclerotherapy just means closing one of the very, very small superficial veins. Only instead of using radio frequency, this is actually a solution which actually causes it to fibrose. Again, same principle, where the walls are closed, they're stuck together. And I think the next slide has some pictures. Yeah, there you go. Of a patient who had sclerotherapy. So that's about it. Hopefully that made sense. My role in it, the combination of ultrasound and radio frequency, the indications for it, and hopefully you'll be able to keep an eye out in the paper. And I know we've had multiple screenings. We're hoping to have more, maybe once a month for a little while. So if you do have more questions, I'm happy to talk about those now or one of the future screenings. Yes?
You just take one treatment to do that? One treatment?
Yes, ma'am. In that particular blood vessel. That's right. Yeah, the 5-year closure rate is in the high 90%. Yes. So just one treatment for that particular vessel.
So each vein that is...
Right. So then you do those separately. Right. Yes, ma'am. Yep. Yes. You'd start with one at a time. So if, say, you could potentially be up to 4 different procedures if it's the great saphenous vein on each side and the small saphenous vein on each side. It's really each procedure is one length of vein. Now it could be this long, you know, but we treat one at a time. Yep.
If you do the greater saphenous vein and then later you have to have a heart valve replacement.
Sure. Well, the good news is, yeah, that's a great question. So the concern was, you know, what if you close the great saphenous vein and then you have heart surgery later? Well, the way I'd answer that is a couple things. One is it probably wasn't a good vessel. They probably wouldn't have wanted to use that one for your bypass anyways, because if it was being treated for venous insufficiency, there was already disease in that. And so remember, when they're bypassing, they're taking blood and they're detouring it around a blockage. So you want to have a good vessel to do that. So my first response would be they probably wouldn't have chosen to use that great saphenous anyways, because if it wasn't a healthy vessel, they wouldn't want to use that as your new one. Also, the data, at least the last time I read, was the best outcomes are for actually using the internal mammary artery, which is on the inside of the chest wall, and they can dissect that from the chest wall, and then they can put that. That really is again, from my understanding, and I'm not a heart surgeon, but that's my understanding, that's the longest lasting, best, what they call the longest patency, is for using the internal mammary artery. Plus they can use arteries from the upper extremities as well. So there's plenty of different places that they can use if they need to find. Yeah, that's a good, great question. Other questions? All right, it was good to see y'all again.